All right, everybody. So we can probably get started now as attendees continue to stream in. I just wanted to welcome everyone to our next SPD Journal Club. We are trying to do these roughly every 3 months. And this is brought to you by the Young Members and Fellows Committee. So we are really excited today to have three excellent authors of really, we think at least, very impactful papers over the last 3 months to come and present to you several articles that they have worked on. And then this is a great opportunity to hear directly from them about their papers, and a great opportunity for us to ask questions as well about their papers too. So the basic structure is going to be one author, one talk, and then for about 7 minutes. And then afterwards, there'll be about a 7 to 8 minute Q&A session. And we're going to do this for all three papers. And at the very end, there will also be an opportunity to ask questions as well. So we're going to try to keep this on time. We're going to try to make this as interactive as possible over Zoom. And I'm really happy that you guys are all here, and I hope everybody has a great time tonight for the next hour. So for the first speaker, I'm going to introduce the moderator, Dr. Lucy Cohn, and she will be introducing the first article tonight.
Hi guys, I am thrilled to introduce our first author and paper of the evening. Larry Eichenfield needs no introduction to this group, so I'll keep it brief. Chief of Pediatric Dermatology at Rady Children's Hospital at UCSD, Larry is a leader of our field. He has held leadership positions in PEDRA, the AAD, the SPD. He served as editor-in-chief of Pediatric Dermatology and was editor of Neonatal Derm. He is here tonight to talk about his most recent paper in JAMA Derm about the safety and efficacy results of a cantharidin device for the treatment of molluscum. Larry?
Greetings. Thank you so much for inviting me to do this. So rather than make up slides, I decided that I'll just put the paper in the background. And so the plan will be to just briefly discuss the paper, and then we'll go to Q&A, but they've already asked if I could also discuss how it is that I got involved in this and got involved with industry in relation to this. So by background, this is not the first formal clinical trial for molluscum that I've been involved in. Years ago, a group of us were involved in testing imiquimod. There was a lot of excitement about imiquimod for molluscum, and we showed in vehicle-controlled study that it didn't work better than vehicle. So this is a study of cantharidin. Many of us use for molluscum, but many people can't get cantharidin due to what happened years ago when the FDA sort of announced that it wasn't formally FDA approved, and some people could get it in bulk substances. So, and we do know that if you do use cantharidin, most of the time it gets mixed up locally, and or the bottles sort of change their concentration over time. You never know how strong it is. Also, like in, if you looked at like Cochrane analysis, they would say that nothing's been shown to be useful for molluscum contagiosum. So this was basically after phase 2 trials. This was a core, traditionally designed phase 3 vehicle control study of cantharidin 0.7% in these unit dose modules. So officially, it's a drug device combination. And basically, this was a really well-designed study where children and adults with molluscum were enrolled. They could have had the molluscum pretty much for any duration, and they could have no limit in the number of lesions at baseline. Other than that, they needed to be able to be treated with 2 of the modules. So I had to skip not in the picture, but from a slide from a recent talk. This is sort of how the stuff looks. This is basically cantharidin 0.7% with acetone, gentian violet as a marker, and a preservative that's used. And it's this sort of squeeze where you squeeze it onto each molluscum, and the purplish color of the gentian violet sort of allows you to place, you know that you placed it where you expected it to be. So basically, so the study ended up having about 530 children enrolled. The design was set up where patients had a 2-to-1 chance of getting the cantharidin as compared to the vehicle. And The age was 2 years or older, and actually the way it ended up going down was that 80% of the population was 2 to 11, pretty evenly. About 40% of them were 2 to 5, another 46 to 11, and then the rest, which did go up into adults as well. It wasn't only wasn't only pediatric, and just to let you know, basically the material, right, the study drug was applied to each of the molluscum that was present in any treatable area. Facial lesions were allowed to be treated, but not just right around the eye. They were applied and they were kept on for 24 hours. So the methodology with this is not a 4-hour wash off, not under occlusion. It's put on, it's dried, and it's washed off 24 hours later. And then patients got treatment at baseline, and then 3 weeks later, and 3 weeks after that, and then 3 weeks after that. So basically at baseline, 3 weeks, 6 weeks, and 9 weeks. And so up to 4 treatments that were allowed. In working through with the FDA, the outcome measure the FDA likes is equivalent to clear, almost clear. They wanted to know what percentage of patients totally cleared their cantharidin, and they wanted 2 separate independent trials, each meeting statistical significance in terms of that. The secondary outcome measure was that clear, almost clear at earlier time points, and the other secondary outcome measures were the total number of lesions that decreased in the active group as compared to the vehicle. So basically the studies, this was cantharidin application in molluscum patients, or CAMP 1 and CAMP 2. It was good to have a pediatric study with that involves camping. So the predominantly pediatric population, diverse population from a racial standpoint. The mean lesions were about 20 to 25 in the different groups, but the range was 1 molluscum lesion up to 184. To be truthful, I think 184 outstrips the capacity, because we figured about 40 is about the amount that you get with modules, but you can get more, but that was pushing it a little bit. And basically the core results of the 2 independent studies show that there was about between 50 and 60% of the patients cleared all of their molluscum in the units of time, as compared to the vehicle group, which was 20% and about 15%. If you look at the lesion counts, so the bars going down in the 2 studies, showed that there was about a 60 to almost 80% lesion count decrease, and not clearing in all the patients, but that's basically the change in lesion numbers. And it's interesting because in one of the studies, the lesion count increased at the end. So the way it worked is you applied it to every lesion that was there and any new lesions that came up. And in one study, it happened to be that in the vehicle group, they increased their numbers over time. In the other, they decreased it by 20%, but way less than 80%. One of the annoying features that the FDA had decided that any local application event was going to be recorded as an adverse event. So we actually had to record every little crust as a adverse event. And adverse events, we're seeing in almost 60-something% of the vehicle group, because probably the natural history of molluscum, or people interpreted the little goo on it as crust. And there was vesicles and pruritus, but they generally did quite well, but with an expectation that you have this sort of blistering and crusting. And one of the ways you could judge that is the discontinuation rate in the study, which was tremendously low. Most patients stayed in the studies in both groups. The study basically went on until with the last application being at day 63, and patients were followed for 2 weeks beyond that. So there wasn't any multi-month check to see if there was recurrence of lesions after that within the limitations of the study. So takeaways is really the first, study to show efficacy of something in molluscum. It showed decent lesion count decreases. I would have liked higher total clearance rates for the application, but again, there was a big variation in the number of lesions treated. There are other analyses that show that, for instance, facial lesions did quite well, something that I would not have thought would have been intuitive, of course, leaving behind the periocular area. So that's the basic core, and let's do Q&A.
All right, so we have some good questions. First off, from Elena Harlock in Boston. I'm worried that this product or patent will create a barrier to access for cantharidin. Do you foresee this interfering with those of us who carry a bottle in clinic and perhaps creating a cost for patient that was previously a clinic supply like liquid nitrogen?
Yeah, so that's certainly, I think that's an interest for an issue. I don't know how it will go down. I mean, if this does get FDA approval, then suddenly you have an officially approved product. And I think probably in private practice, it won't change much if people have their cantharidin. I think in big centers or big groups, whether they be private or university or whatever, there may be pressure to use the approved, the officially FDA approved product. So that's something that I think will play out in terms of marketing and access. Of course, on the other hand, if it's not accessible from a cost standpoint and reimbursable by insurance, then it won't be successful. So we'll see how that plays out.
Another question along those lines is this product commercially available right now? And when do you anticipate it will be if it isn't?
So the PDUFA date, as they say, which is the farmer response date's coming up in the next few months. And you never know if it's going to be approved at that point. But if it is approved at that point, usually after approval, it still takes a few months for it to come to market. But I mean, there's a good chance it could probably be in our hands in 4 to 6 months. So I don't have any special insight on the when.
Okay. And Bree Zimmerman asks, do you think the device could be used for home application by parents?
No. So because you remember cantharidin is Spanish fly and it could be toxic. The plan I think was always to have it. It's a toxic enough agent that the deal with the FDA is that it would be done for unit application. I do think there's a chance that pediatricians may pick it up as something they could do because, to be truthful, they probably could. They could get trained pretty easily, but there's no intention for it for home use.
Okay. And Bernie Cohen asks, what's the longest follow-up after all lesions cleared?
Yeah, so I mean, in the study, they basically went 2 weeks beyond the final study, the study application. So they didn't get beyond 3 months total.
Okay. And I think your study, did it stratify by molluscum dermatitis or molluscum abscesses?
No, it didn't. It was just all. I think if someone had active abscesses, if they had active secondary infection other than molluscum, they were excluded. But molluscum dermatitis was not a molluscum dermatitis, if it didn't interfere with the assessment of the molluscum lesions, was an exclusion, but it wasn't stratified for that.
Okay. Diana Lee asks for logistics. So would the patient be prescribed the medication and then they would bring this to the clinic, or would the clinic just stock this?
Yeah, so probably both. The company, and this is just my in discussions with the company, they're trying to figure out the model, but I think they're looking for a model where it would be sort of like the Levulin sticks that people use. I haven't had experience with that, but that's a model that they use, where it would be a specific item that in some cases would come from pharmacy, paid for out of the prescription plan. In other cases, it would be sort of like a supply that would be stocked in the clinic so that you wouldn't have to send someone out to do it, and then it would be charged back to insurance.
And I think this might be our last question. Rabina Walsh asked, do you think the gentian violet is contributing any way to efficacy and with secondary infection?
Yeah, so probably not, given that there was such a differential between the active and the vehicle. So, but in terms of as you know, I mean, look, how many times do we get? My experience with cantharidin is I don't get a lot of secondary infections with cantharidin in the clinical practice. I occasionally have seen infections of people I've treated, but whether it has an effect, I don't know.
Okay, I think those are all our questions.
Well, let me just do, so Jeff had asked me questions about how do you, what's been your story? What was it like working with industry for this? So can I give 2 minutes on that? So every interaction with industry is different. This was a case where they were considering this and they grabbed me at like an AAD meeting and said, hey, can you meet with the usual thing? Can you meet with us to discuss some stuff? And I talked to them about it. And then they asked what would be the feasibility of doing a trial on molluscum. Would that be easy or hard? And I said, I don't think that's hard because we got unlimited molluscum patients. And subsequently, I helped to look at the study design for them. They asked me to be the principal investigator, thus my name is there. And they've been very straightforward. These are people I knew from other companies in the past, and they've worked it out. But I have a conflict of interest now because I'm actually on the board of the company. Recently, they asked me to do that, which is a whole different world of looking at how companies do what they do to try to get a drug into marketplace. But that was all done after I had fully completed my work as a principal investigator, because we were totally separate. I took no money from the company before that because as a PI, I was totally separate. And then about 9 months to a year after that, they asked me to do more with the company.
Perfect. That's really helpful. Thank you so much for going into that. I think, some of us are approached by industry and we're not really sure what the relationship's like. So it's nice to have a little bit of foresight into what that would end up being.
And, you always have to be careful. Right? You make sure that sometimes when there's a mutual interest, that's good, but they're not always aligned.
Right. Well, thank you so much, Larry, for that wonderful presentation and those wonderful, questions from the panelists and your great answers to them as well. So if you have other questions about this paper, please, leave it in the Q&A and we will get to it if we have time at the end, okay? So the next paper is going to be moderated and the speakers will be introduced by Dr. Grant Plost as well. Dr. Grant Plost. Thank you.
All right. We are excited to welcome Trevor Young and Dr. Oza, who will be presenting their paper entitled Mucocutaneous Manifestations of Multisystem Inflammatory Syndrome in Children During the COVID-19 Pandemic. Trevor is a fourth-year medical student at NYU, and we're excited that he recently matched for a dermatology residency at University of Pennsylvania. And Dr. Oza is an assistant professor in the Department of Dermatology and Pediatrics at NYU, where he serves as Division Director of Pediatric Dermatology and the Associate Program Director for the Dermatology Residency Program. Again, welcome Trevor and Dr. Oza.
Hi, thanks. Let me share. Okay, thanks for the introduction. So I'm going to be doing the first part of this, presenting our paper, Mucocutaneous Manifestations of MISC During the COVID-19 Pandemic. So a little background on MISC. So when the COVID-19 pandemic started last year, there were initially reports that children were largely unaffected by the virus, but shortly thereafter, there had become reports of a Kawasaki disease-like illness in children characterized by multi-organ system involvement, fever, and systemic inflammation began to affect children all over the world, really. And so this was later named multi-system inflammatory syndrome in children, otherwise known as MISC. And so when the initial reports of MISC began to emerge, a lot of case series had reported that rash or mucosal findings were seen in a lot of the children, up to 75% of them, but no study really detailed the morphology of these eruptions. And so we really saw that as a gap that we could fill using the patients that we had been seeing at our own institution with MISC. And so at the time when our study was conducted, there were no previous studies that reported the morphologies of these eruptions. And so we conducted a retrospective chart review of 35 children at 2 of our affiliated hospitals here in New York City between April 1st and July 14th, 2020, who met either CDC and or epidemiological criteria for MISC. And the way these patients were recruited was any patient who came in during that study period to our hospital, it was our hospital protocol for any child with a fever of unknown origin to be seen by pediatric rheumatology and infectious disease. And so we actually used their consult lists and applied our inclusion and exclusion criteria to those patients to include them in our study. And we essentially documented their clinical characteristics and the morphologies of their eruptions. Patients were included as either confirmed or probable MISC based on whether or not they had a known COVID-19 exposure or lab testing. And so briefly, these are the guidelines that we used from the CDC. So this was published on May 14th, the CDC case definition. And essentially, really the exposure or exposure or suspected COVID-19 exposure or positive laboratory testing was what we used to define whether they were a confirmed MISC or a probable MISC when we ultimately published the study. And so we had 35 total included patients, 25 met the CDC definitional criteria for MIC. 19 of the 19 were IgG positive and 10 patients were PCR positive. There were a few who were IgG and PCR positive. And there were 10 additional patients who we included as probable MISC cases. And we felt that it was important to include these 10 patients for several reasons. The first was that we did not want to skew our analysis. We really wanted to include the spectrum of the mucocutaneous eruptions that were presenting to our institution during the study period. And secondly, during when New York was hit hardest by COVID-19, the sensitivity of the COVID testing was lower than it is now. And additionally, it's been estimated that using serological studies now, up to 20% of all people in New York City were infected or exposed to COVID-19 in the spring of last year, less than 10% who were actually diagnosed. And so of the mucocutaneous findings that we saw among our cohort, 83% of children had one or more mucocutaneous changes. And the majority of those had 2 or more discrete findings. In terms of how we evaluated for the findings, about 25% were in-person evaluation by dermatology, so they had a dermatology consult during their admission. The majority was through review of photographs in the chart, and then for a few patients, we used documentation from our pediatric rheumatology specialists. In terms of the demographics of our cohort, the average age was 2, which is younger than most other series that have been reported on MISC, which tend to be around 6 to 8. Black and Hispanic children were largely disproportionately affected in our cohort in New York, and we believe that to be due to communities of color really being disproportionately affected by COVID in general. And in terms of the mucocutaneous findings, fever often preceded rash by several days. And in terms of the duration of the findings, it was very protean in that some would be present for hours, some would be present for days. And so there was a median of 5 days for mucocutaneous findings. So kind of really what we did the study for was to what the findings actually were. And so figure 1 shows the acrofacial findings. So conjunctivitis was the most common finding seen in 60% of children. We also noted palmar plantar erythema in about half, and lip changes were very common as well. Very Kawasaki disease-like presentations. We also noted a very marked periorbital erythema and edema reminiscent of a heliotrope rash in about 20% of our patients. Strawberry tongue was seen in about a quarter, and then a marked malar erythema we saw in about 17% of our patients as well. So these are just a few photos that didn't make final publication, but just to share of some of the lip changes that we saw as well. And then in figure 2, we have just additional exanthematous eruptions that we saw. These were generally non-specific in nature. And so we saw morbilliform, scarlatiniform, urticarial eruptions, a reticulated eruption, and macular erythema as well. And these were not as common, but we still saw them in our patients as well. Because of the overlap with Kawasaki disease, we looked for desquamation after resolution of the findings. And so we noted that in about a quarter of patients had palmar plantar desquamation as well. And this was within the first month after they were discharged from the hospital. We also, in terms of overlap with Kawasaki disease, so 60% of the patients that were included in our study also met American Heart Association criteria for either typical or incomplete Kawasaki disease, unsurprisingly, given the clinical overlap. And 4 patients met criteria for Kawasaki shock syndrome, which is a drop in systolic blood pressure of at least 20 during the acute illness. In terms of other organ system involvement, GI was involved in almost all of our patients, and that was usually manifested by abdominal pain or vomiting. About half of patients had some form of cardiac involvement, and this was, we evaluated this using either elevated troponin or BNP, or changes on echocardiogram. And we saw both a myocarditis-like picture in several patients, as well as coronary artery changes in several patients. Almost all patients had an elevated D-dimer, but importantly, none of the patients in our cohort had any thromboembolic phenomenon. And all of the patients made a full recovery and were discharged home. Some took longer than others and required PICU admission, but they all did make a full recovery. We also wanted to look at whether any specific mucocutaneous findings could serve as prognostic indicators and disease severity for these kids. And in our study, we found that there was no significant association between the presence or absence of mucocutaneous changes with cardiac dysfunction, the need for inotropic support, or ICU admission. However, we wanted to emphasize that because of our smaller sample size, it's important to take that into account with these findings. So take-home points from our study were that among our cohort of 35 children, similar to other studies that have been reported, mucocutaneous findings were seen in most patients, but not all. The mucocutaneous findings that we did see were really polymorphous in protein and nature, and there were several like conjunctival injection, palmar plantar erythema that were seen in at least half, but it wasn't universal. The most common findings were acrofacial eruptions, non-purulent conjunctivitis, and lip changes. And although many of the findings did closely resemble those of Kawasaki disease, there were some that we noted that were not typically associated with Kawasaki disease. So a periorbital erythema and edema and prominent malar erythema we saw in some of our patients. And based on our study and the analyses that we did, mucocutaneous changes were not associated or could not be a marker for disease severity in MISC, but again, because of our small sample size, this limits the generalizability of that statement. And we also just want to acknowledge that since our study has been published, there have been several other case series as well that have looked at similarly at the mucocutaneous findings in MISC. And I think the take-home point at this point in the literature is that these findings are very polymorphous, and there does not seem to be a clear constellation of findings or a clear individual finding of MISC that really can serve as a diagnostic indicator for the syndrome. I think it's also worth noting that other studies have found different relationships in terms of the presence or absence of mucocutaneous changes with disease severity. And all the studies have kind of reported different things. So I think it's still an unknown as to whether certain findings can be a marker for disease severity. So this was our study team. We worked with PEDS room and infectious disease very closely on the study, as well as the dermatology department. And thank you so much for your time. And we're happy to take any questions.
All right, thank you, Trevor, for that wonderful talk. For those who would like to ask questions, I just remind you to please enter them into the Q&A section of Zoom. So one thing I had a question about in listening to your talk, Trevor, is could you talk about, did you guys look into management of the mucocutaneous findings? It seems like dermatology was only involved in a minority of these cases by consultation.
We did. So the vast majority received IVIG. And I think that a lot of that was because we were really on the front end of when MISC emerged. And I think that rheumatology was really managing these patients as Kawasaki disease. And so the vast majority received IVIG and aspirin. There were several that also received anakinra as well.
Yeah, well, that was great job, Trevor. The backstory was that like kind of everyone, I think we got back to work June 1st, and we were very itching to do stuff. And we started getting multiple admissions almost each day during the very end of May and start of June. So at the front, dermatology would see all patients that were admitted with MIS-C, whether they had dermatologic findings or not, just to get a sense of what was going on. And then as time went on, kind of our other colleagues, we got a sense of what was going on, and then we kind of were able to review photographs taken by most of our other colleagues in the other departments.
A question we have from Diana Lee is, were children with COVID who did not have MISC have any derm findings characterized?
Well, in the study, we didn't that was sort of one of our inclusion criteria, was that we didn't look at children admitted with COVID-19 without meeting a criteria for MIS-C. There have been other studies that have looked at that, like Antonio Torello had published an article looking at COVID-19 with mucocutaneous features, period, at a children's hospital. And it seems like the minority of those types of patients have mucocutaneous features. Although in his kind of small study, it did seem that children with acute COVID-19 and had, for instance, rashes, like morbilliform rashes, seemed to stray on the sicker side, but it wasn't something we specifically looked at in our study.
Next question from Robert Silverman is, did you see nail or paronychia or nail fold telangiectasia changes?
Nail fold telangiectasias, I don't honestly, we didn't specifically do nail fold capillaroscopy. So not that we noticed, but I can't say that we noticed any periungual change. I think when this all happened, this was after a month of just getting inundated with COVID toes. So that was one of the things that we're specifically kind of looking at the very early onset in June, whether we saw sort of any acral purpura. And so we didn't see those findings, but we did see a subset of patients that did have characteristic desquamation, like what was seen in Kawasaki's, in a subset, not in all patients.
All right, well, thank you very much for your time, Dr. Oza and Trevor.
Yep, of course, thanks for having us.
Wait, one other question, sorry, that just came in late. I think we have time, from Colleen Cotton, is do you think learning about these cases of MIS-C will improve our understanding of what causes Kawasaki disease or what might be going on?
Yeah, I mean, I think from an immunologic standpoint, I certainly think so. I mean, I think there's just been so much deep dive into the immunopathogenesis of MIS-C that we're learning about. So I think it will. I mean, it seems very striking that these are two distinct conditions. They're also two distinct conditions immunologically. I think there's still so many unanswered questions. It's so clear that this is occurring 2 to 6 weeks after an infection. Why does the immune system sort of become dysregulated in that setting, I think is still very interesting. What role are there persistence of SARS-CoV-2 at privileged sites, like the gut? And is that why kids initially present with GI symptoms? And is that what there's still a persistent antigen in which there's an immune response to? So I think there's a lot of things. And so, yeah, I think there will be sort of corollaries that come out from our understanding of the immunology of what's going on that may even help kind of our more complicated Kawasaki's patients as well.
All right, thank you again. We appreciate your time.
No problem. Thank you.
Great. Thank you so much, Kashi and Trevor. That was amazing. So for our last paper, Dr. Joy Wong will be introducing the next speakers. And thank you guys so much for the amazing questions. Keep them coming. And if you have any questions about the first paper or the second paper, please type them into the Q&A and we'll be sure to get to them at the end if time allows.
All right, great. And so I'm thrilled to present Dr. Erin Roberts, who's going to lead the discussion on her paper on the use of Sporolactone to treat acne in adolescent females. Dr. Roberts attended medical school at Loyola University in Chicago and completed her dermatology residency at the Mayo Clinic, during which time she completed the work that's being presented today. And currently she's in private practice in the Dallas-Fort Worth area, where she takes care of both adults and children in her practice. And then I will mention quickly that Dr. Nosheen, who was supposed to be with us today to kind of co-present with Dr. Roberts, couldn't make it because she's a transitional year resident and is actually on an inpatient service. So we're sad that she couldn't be here, but Dr. Roberts, I'll let you take it away from here, okay?
Thank you. And thank you for that kind introduction. Just pull up can you see my slide okay? Okay.
Yes.
So as she mentioned, my name is Erin Roberts and I am a general dermatologist working in the Dallas-Fort Worth area. And I would like to thank the Society of Pediatric Dermatology for the invitation to speak tonight. I was especially excited to talk on this topic as acne is at least very near and dear to my heart, as I see it and treat it on a daily basis. I think during this era, finding treatments that are alternatives to antibiotics are very important with the rise in antibiotic resistance and the need to be good antibiotic stewards. I think many of us have used spironolactone for many years, but to validate that it's effective and safe, especially in the adolescent age group, was, I think, very important. So just jumping into our study, it was a retrospective review that looked at female patients aged less than 21 years old who were evaluated and treated at the Mayo Clinic in Rochester, Minnesota, with spironolactone for their acne. 80 patients met inclusion criteria, and this required, females with a diagnosis of acne who were seen and diagnosed in our Department of Dermatology. They had to receive spironolactone for at least 3 months and have one follow-up visit, which was at least 3 months after spironolactone initiation. We looked at our electronic medical record to look at patient demographics, clinical presentation, concurrent treatments that they were also on for their acne, and the response to treatment. So, looking at some of our patient characteristics, the median age of our cohort was 19 years old. So we included, like I mentioned, patients that were less than 21 years old. The range was between 14 and 20 years. We also looked at if they had findings that are normally associated with hormonal acne, such as a history of PCOS, acne located on the jawline, acne that flared with their menstrual cycle. And then, like I mentioned, we looked at other treatments they were on before spironolactone and if they were unresponsive to these treatments, and other treatments they might have been on while spironolactone. The big thing here was the oral contraceptive use, and if patients were started on an oral contraceptive around the time they were also started on spironolactone. We really wanted to delineate to make sure it wasn't a response to the OCP. So we separated if the OCP was started greater than 6 months before spironolactone initiation or less than 6 months before. And of note, that oral contraceptive pill had to be one that is FDA approved to treat acne. We also looked at, if it was, like I mentioned with the other treatments, we looked at if they were on other treatments like antibiotics, isotretinoin, or topical therapies. Of note, none of our patients were on isotretinoin at the same time as spironolactone. So looking into some of the results, and I've highlighted some of the results, not only because they were nice to see, but also because, at least for me, they have impacted my daily clinical practice, especially when counseling patients about spironolactone. I sometimes bring up these numbers to talk about. So for example, the median spironolactone dose used in our study was 100 milligrams, with the range being between 25 milligrams and 200 milligrams. Again, I think this is very important because when I talk about a starting dose for spironolactone, I'm really either starting at 100 milligrams or quickly trying to escalate to this dose, because I don't want patients to be considered spironolactone failure if maybe they just weren't at an adequate enough dose. And then looking at the response rate, obviously this is very important. 80% of patients had some improvement with therapy. A quarter of patients had a complete response, which we defined as greater than 90% improvement in their acne. 36% of patients had a partial response greater than 50. 21% of patients had a partial response less than 50, and 20% of patients had no response. And these patients were then subsequently treated with isotretinoin. We also looked at the time to initial response and time to maximum response. So the median time was 3 and 5 months respectively. And again, I think these numbers are extremely important. As I try to counsel my patients, spironolactone is not a quick fix for acne, and they really need to be on it for more of the long term. I really don't want patients being considered a spironolactone failure unless they've given it a good amount of time to try and get it to work. And again, I think some of this we've always kind of known about, but it was nice to kind of validate it through research. We also obviously wanted to determine the safety of spironolactone, and fortunately, a very small percentage of patients had any adverse effects, around 4%. The most common adverse effects were things we usually think about with spironolactone, so headache, breast tenderness. One patient had diarrhea and a rash. Lastly, we did classify patient demographics based off of the response to spironolactone therapy. And one particular thing I wanted to point out was that patients who did respond to spironolactone were more likely to have those findings that we commonly associate with hormonal acne. So that history of PCOS, acne on the jawline, cyclical flares of the acne, et cetera, they were more likely to respond. So again, we're commonly taught this about spironolactone, and knowing its mechanism, it makes sense. But again, it's always nice to validate it through research. The study really showed that spironolactone is a safe and effective treatment for acne, especially in the adolescent age group population. So I hope you all continue to use it. And thank you again very much for inviting me to talk, and I'd be happy to answer any questions.
Great. Thank you, Dr. Roberts. So if anybody has any questions, please, feel free to drop them in the Q&A box. So we do have one question to start us off. Robin Garris asks, is there any lower end age in which or in whom you would not use spironolactone? So sort of just asking about, what is the youngest age, right, that you would consider potentially starting this, or or is it not completely age dependent, but perhaps dependent on other things?
Yes, that's a great question, because I know, we commonly see younger patients coming for acne, and, it's always, can we use spironolactone? In this study, we looked at, like I mentioned, the age was between 14 and 20 years old. In my own practice, I, have heard of people using it when, females have reached puberty and have had menstrual cycles. Then we think, because it is that hormonal mechanism, that it is safe to use in this patient population and may be effective in this patient population. So for my own practice, even if I have a 13-year-old who comes in who's, regularly getting periods and has already entered puberty, then I regularly use it. Before that, then I think, it's kind of up to the individual provider, but I don't think necessarily there's a definitive cutoff in age.
Great. And then Diana Lee asks, how long did the patients stay on spironolactone generally? And what is the recommended, duration of use, from sort of what you've seen in your institution and, through your practice? Because I also agree, you had mentioned that the median duration of treatment was about 7 to 11 months, but the time to max response was a little bit sooner, so close to 5 months. So clearly there's probably some patients who are continuing on for, beyond the max response timeframe.
Yes. I'm really, at least trying to keep an eye on it for at least 3 months before we talk about stopping. The maximum time, again, like we mentioned, the maximum time to respond was around 5 months. But obviously, if patients are tolerating well, at least in my own patient population and from my experience, I think people are usually happy with spironolactone, especially if it's working. So they like to stay in it long term. I don't think there was any, I don't think there was any, maximum duration that we really need to talk about stopping the medication. I know in my own practice, especially because, yes, maybe we use in that adolescent age group, but it's a really nice medication with females who continue to have acne into their 20s and 30s. So usually we start talking about stopping the medication when, females want to get pregnant. So that's kind of when that discussion comes up for me. But I don't think there's, I think they can be on it as long as they're happy and tolerating it well.
Great. We had two folks kind of with the same question. Christina Derrick and Vikash Oza both asked any issues, any irregular menses perhaps in the group that was not taking OCPs, but who got spironolactone.
Yes, it's definitely a concern because it can cause menstrual irregularities. So that's why the OCPs might be useful. We looked at, we did the same study in the adult cohort population, and we actually found that our pediatric population was less likely to be on OCPs. And I think this is because, it's, I think, harder with a teenage patient. Parents are sometimes hesitant about starting OCPs in their teenager. So, it really wasn't as commonly used maybe as into like the adult population. I don't think, at least in my own practice, I definitely prescribe spironolactone. I don't require it to be on an OCP, but generally I think the OCP can be nice because it can treat acne as well, but it also, gets rid of any of those side effects. In general, I think the side effects are still really low and relatively rare. So I think it's okay, even if they're not on a OCP, I don't think it's going to mean, yes, they're definitely going to have menstrual irregularities or anything, because I think a lot of patients, large majority, tolerate it really well anyway. So I don't think you need the OCP to prevent the menstrual irregularities, but it is nice if they want to be on it anyways.
And then kind of on the same topic of OCPs, you mentioned that you don't always combine, but Francisco Colon Fontana's also asked, does spironolactone work better, in combination with OCPs or alone? And have you guys looked at that at all?
Yes, and let me pull up I'm going to share my screen again so I can share that one graph. So, we looked at we kind of separated this into responders and not responders. And if the patient was started on OCP greater than 6 months before spironolactone, or if it was less than 6 months before spironolactone, because this was trying to, as best as we can, delineate, was there any improvement with just the OCP alone? So, like 51% of patients who responded, or the OCP was started before spironolactone. So we think, the OCP probably, in our study had not as much of an effect, and it was mostly just the spironolactone. And then, for the patients who were started on the OCPs less than 6 months before, we thought, or like at the same time as spironolactone, we thought maybe the OCP could have also had an effect. So here are some of the numbers there. Again, people respond to OCPs very differently, especially when it comes to acne. So, I don't think necessarily it means like, yes, your acne is gonna respond a lot better if you also start an OCP. But, some patients do get that improvement with that OCP.
And then kind of, we have, a couple more questions to relate to the OCP spironolactone space here. So Stephanie, they ask, I've seen providers start spironolactone without beginning OCPs, while I've also talked to others who will only start it spironolactone only after beginning OCPs because of the concern for pregnancy while on spironolactone. So what has your approach been in terms of starting spironolactone while weighing against the pregnancy risk?
I think that's a great question. We talk about this a lot, especially because if it is teratogenic, it is going to happen very early in embryogenesis. So I've heard the same thing. Some providers really only use it if the patient is on an OCP. In general, I think spironolactone works really well for acne, and I would hate to limit its use at all. And I think for some patients, and especially in this age group, some of the parents are really hesitant to putting their teenage daughters on OCP. So I would hate to limit its use just because the patient's not on an OCP. So for my own personal practice, I prescribe the spironolactone, even if the patient's not on an OCP. I counsel the patient about not to get pregnant on this. And especially as my patient becomes, older and we start having these conversations, I remind them of the importance of not getting pregnant on spironolactone. But for me personally, I don't not prescribe it if they're not on an OCP. Just because, again, we only have so many treatments for acne, and I would hate to limit, one of the good treatments.
Great. And then Jillian Mann asked about the potential for combination therapy with spironolactone and isotretinoin, because she's had some good responses in some patients, especially with hyperandrogenism. And so she wanted to get your thoughts on why perhaps we don't use that combination a little bit more often. Yes. And I think there were a few people in your study that were also in combination with isotretinoin.
Yes, there was none in this age group, but like I mentioned, I did do the same study with the adult population, so everybody greater than 21 years old, and that had about 400 patients in that study. So a lot higher power, and some of those patients were on spironolactone and isotretinoin, and I agree. I think if you have a patient on isotretinoin who really isn't getting the response you wanted, or if has a really large hormonal component, I love adding in spironolactone. I think it works really well. Or if they're on spironolactone but you want to add in a low dose isotretinoin to really kind of clear up any remaining, I think that's a great option. And like I said, our adult population, we did look into that a little bit and found it was useful. Great.
And then there are a couple of questions regarding just side effects again. So Dr. Eichenfield had said breast growth and tenderness is common, but do you think that the low adverse event rate that you found in your study might be related to just the retrospective nature without specific queries about side effects, or, was there sort of a more systematic way of assessing side effects, either through just the practice of the group or whatnot?
For sure. Because this was a retrospective review, we gathered all of our data just from, chart mining, and if the patients or if the provider didn't document the side effect, or, wasn't clear in the note, then yeah, that definitely could have been missed. So I think that's one of the limitations to a retrospective review. That being said, it has been reassuring to see a very low profile in similar studies. Again, there's a really limited amount of data in the pediatric age group, but there's been more data, especially recently. I think UPenn actually just published a study on spironolactone in adult population as well. And I was looking at their study, and they also had a very low rate of adverse effects. So even though a lot of these might be limited by their retrospective nature, because I believe UPenn's paper was also retrospective, it's nice to see the consistency across all of them.
Yeah, absolutely. And then we had a couple of folks want to ask just about monitoring potassium levels. Do you need to? If you do, how often would you? And, love to kind of hear your perspective on that.
Great question. There was no standard protocol at all at our institution about monitoring potassium and creatinine. Of note, when we were kind of going through all the charts and looking at the review, we did find that providers routinely monitored that before 2015. And that was really when that JAMA article came out in 2015 about the usefulness of monitoring for potassium in young, healthy women. And kind of after that, landmark paper came out, the routine monitoring of potassium and creatinine really, decreased a lot. And now it's really based off of the patient's history and their review systems. So now in my own practice, I'm always asking about personal family history of kidney disease, any concurrent therapies they might be on that could also increase the potassium. And I go over the risk about, how this medication can increase potassium and to be aware of it. And this is all for what that, I kind of go based off of that JAMA article, which talked about young, healthy women. So this is all for patients less than 45 years old. So obviously, if your patient is, greater than that, then I am routinely checking potassium and creatinine.
And then any concern about, blood pressure and whether any need to check it at all if they're otherwise young and healthy?
Yeah, that's a good question too. We didn't have a standard protocol to check blood pressure with spironolactone at our institution. I do go over that risk with patients and talk about, if they are getting lightheaded, this that could be related to the spironolactone. I find in my, own practice, most patients tolerate it really well, maybe in the beginning, with some time. So maybe in the beginning they feel a little lightheadedness, and then you become more accustomed to it. And I know in my own practice, again, this is just kind of from personal experience. Like I talked about, I really love the 100 milligram dose, but I actually start patients, I'll tell them to break the tabs in half, take 50 daily for the first, week to 2 weeks to make sure they're tolerating okay, because I really don't want to make someone, really orthostatic, from day one, and, have any side effects from that. So I start low just to make sure, really, because of that lightheadedness, that they tolerate it okay. And then I tell them to take a full tab. So that's for my own practice.
Great. And then Mika Fennell asked, do you find that the topical regimen that you prescribe for your patients who benefit the most from spironolactone differs from the topical regimen, that you might traditionally give?
Yeah, that's a good question too. I don't think so. I think I'm still using, the stuff we love for our topical regimen in acne. So, I love putting all my patients on a retinoid. I love the PP washes and kind of all the common things we think of. So I don't think specifically it would change. I think it is interesting, there is that new product, the topical, and I'm blanking on the name, the anti-androgen, topical cream. So I think it's like spironolactone topically. But, I think So, I think it would be interesting, will patients on a combination of that plus oral spironolactone do better than they would have before, since this is kind of hormonal. So I think that would be interesting to look into, but just kind of our typical run-of-the-mill topicals, I don't think they, respond any better to certain ones if they're on spironolactone.
Great. And then I think our final question for this paper comes from Colleen Cotton, who asks, I'm kind of circle back around to kind of what we started on, which is treatment, patient selection for treatment. Were any patients in this study treated with spironolactone who had not had their first menses or had not had regular periods for a year? Because I think in some people's practices, they sort of don't just look at age, but also look at, when menses began and sort of how regular they are already in their menstrual cycles.
Yes. No, all of our patients were having reached puberty, having regular menstrual cycles. And I think that's where the lowest end of our age range was 14 years old. But yeah, all those patients were kind of having menstrual cycles and everything.
All right, wonderful. Thank you for answering all those questions, Dr. Roberts.
That's great. Thank you for your time.
Perfect. Well, thank you everybody for your active engagement in this journal club. It's been really fun to do these every 3 months, and then we will continue to do them every 3 months or so, and we will pick out the papers and we will send out the emails as well. So I really thank you guys for spending an hour with us tonight. We look forward to seeing you guys again next time. I want to thank all of the presenters tonight. You guys all did an amazing job presenting your research, and thank you so much for the moderators and the other committee members of the SPD committee that are putting this together. So I hope everybody have a great night, and until next time.